Today I'm going to talk about a study we called DF-Life. It's a study on quality of life in FDMAS, including quantitative and qualitative approaches. We conducted this study in Edouard Herriot Hospital in Lyon, France, in the General FDMAS Reference Center. Quality of life studies already showed an impairment in FDMAS compared to general population by using standardized questionnaires. With this study, we wanted to concretely understand what FDMAS patients live. To let them tell us about their experience, we decided to carry out qualitative study using focus group, a method drawn from the social sciences. 30 patients took part in the qualitative study, like in the focus groups, and were mostly women, about 46 years old. 58% had a monostatic lesion. First, we have observed a round variability in the experience of illness. Some patients had no or a few symptoms, whereas some were highly disabled. We talked about the time of diagnosis. Some patients went through years of pain before they finally got an answer. For them, diagnosis was seen as a relief. About the physical symptom, we found that pain was the dominant one. Many patients talked about crises of varying duration that could occur randomly or be triggered by some movements. Some talked about permanent pain. It was difficult to establish a model in the evolution of disease. Some patients observed a decrease of these symptoms after years, while others reported a reactivation of pain after years of peace. Beyond the physical impact of FD, the psychological impact was mentioned in all the sessions. It was sometimes described as more disabling than the physical symptoms. Chronic pain, a lack of recognitions, fear of fractures could contribute to a thymic decline or anxiety. Depending on the FD lesions, patients were limited in their ability to walk, do housework, carry heavy loads. Patients often had to curb their activities because of pain, lameness, or tiredness. Despite all these limitations, FD patients talked about rich living experience. The idea of living as anyone else seemed to be important for them. Many patients talked about a growing form of wisdom, like an acceptance over years. Therapy habits widely varied from patients to patients. Some had been relieved by bisphosphonates, whereas some could find no treatment to relieve their pain. Many patients talked about alternative methods to manage their pain. Physiotherapy, sophrology, CBD. We found out that they were very active in looking for any method that could help them with their symptoms. Several expressed the idea of being advised on this subject by their doctor. Finally, their main complaints were about the lack of recognition, the diagnosis wandering, the few caregivers knowing about their disease, and the lack of effective therapies. In the future, they accept the creation of multidisciplinary care network, psychological follow-up, and to keep meeting each other as they did during our sessions. In conclusion, this study highlighted the heterogeneity of FD experience. Thus, it is challenging to establish a pattern of FD patients. It encourages us to find new assessment tools. Despite all this, many patients seem to adapt well. We also have to admit that there remains a lack of effective therapies and that we should always offer our patients a multidisciplinary care network.